All right, welcome back to the Anesthesia Learners Academy. Today's explainer is an absolute must-watch for high-yield learners. We are going to completely master the immediate preoperative sequence for general anesthesia. Basically, we're breaking down the exact chronological, physical, and even the psychological steps of preparing a patient, and we're getting this straight from the trenches, from the real-world perspective of an experienced resident at Mount Sinai Hospital in New York. So we're tossing the textbook aside for a minute and looking at what actually happens in the clinical reality. To help reduce that overwhelming cognitive load on your very first rotations, we've mapped out a foolproof 5-step sequence. We're going to hit the prologue of IV setup, move into placing essential monitors, tackle the pre-oxygenation process, look at induction vitals, and finally dive into patient management. Okay, let's jump right into our prologue, the initial IV setup. Now, before we even officially start the induction stages, getting intravenous access is absolutely paramount. Sure, sometimes the nursing staff handles this, but in major academic teaching hospitals, you, the anesthesia resident, are often the one placing that initial IV right out in the pre-op holding area. And let's think about the actual physical reality of this. You place the IV in holding, right? But to physically roll that patient down the hall and into the operating room, you usually have to disconnect the IV tubing. So listen closely. Your absolute first task, the second you cross the threshold of the OR, is reconnecting and testing that IV line before literally anything else happens. You flush it, you make absolutely sure it is running beautifully. Because trust me, there is no worse feeling than realizing you've lost IV access right as you're about to push induction meds. Moving right along to stage 1, placing essential monitors. Boom, the IV is secure. Now it's time to wire the patient into the vital sign tracking equipment. You need to lock these 5 non-negotiable monitors into your brain right now. First up, the blood pressure cuff, and you'll set that to cycle every 3 to 5 minutes. Second is your EKG, using at least 3, but honestly usually 5 leads. Third, slap on that pulse oximeter, which is brilliant because it's doing double duty, tracking both blood oxygenation and heart rate at the exact same time. Fourth is the thermometer, and fifth is your CO2 monitor. Now that last one isn't taped to the patient, it's attached to whatever breathing device you're going to be using. Actually, hold on. Here is a super important clinical caveat regarding the sequence, mostly just for patient comfort. That thermometer, you almost always wait to place it until after the patient has completely gone to sleep. It's a tiny workflow tweak, but honestly, it makes a massive difference to the comfort of the person lying on that table. All right, stage 2, the pre-oxygenation process. So, your monitors are actively beeping, everything's placed. Now we transition into physically optimizing the patient. This step is absolutely crucial, takes about 2 to 3 minutes, and creates a huge physiological shift inside the lungs. Think about it. Standard room air, what we're all breathing right now, is actually mostly nitrogen, like 78%. But our clinical goal before we knock out their drive to breathe, we want to get the air in those lungs as close to 100% oxygen as humanly possible. Which brings us to a massive, high-yield academic term you've just got to know, denitrogenation. It is the literal scientific mechanism behind pre-oxygenation. You are actually washing the nitrogen out of the patient's functional residual capacity and replacing it with pure, unadulterated oxygen. You're building a massive safety buffer before they stop breathing on their own. And the magic number you're looking for on the monitor is 90%. If you can effectively denitrogenate the lungs and see a 90% oxygen concentration, you have just built yourself a fantastic physiological safety net. Hitting that target means you are in a rock-solid, secure position to safely move to the next step, starting the induction. And that brings us to stage 3, induction of anesthesia. Okay, this is it. The high-stakes moment in the OR. You're administering a carefully calculated cocktail of medications to seamlessly transition this patient from awake to completely asleep. And during this window, your internal monologue needs to be firing on all cylinders. You have to aggressively watch for a drop in blood pressure. This is huge, right? Because the anesthetic agents we push notoriously cause a steep decrease in BP. You also have to be hyper-vigilant for any sketchy EKG changes, any sudden drops in oxygen levels on the pulse ox, and of course, any signs of an adverse drug reaction, like, is their skin color suddenly shifting? Are the ventilator pressures unexpectedly spiking? You're watching it all. Now, propofol is by far the most common induction medication you're going to reach for. And the craziest thing about propofol is its sheer mind-blowing speed. It kicks in within roughly 10 seconds. 10 seconds. In that incredibly tiny window, the patient completely loses consciousness. And from that exact second forward, they literally stop forming new memories until they wake up safely in the PACU. Let's switch gears slightly for stage 4, patient management and soft skills. Look, you can have the hard clinical checklist down cold, But remember, you are performing these highly technical tasks on conscious and, frankly, often terrified human beings. In your first few months as a resident, you might do 250 anesthetics, 200 of them general. That is a massive spectrum of human anxiety and weird personalities. Managing the person is just as vital as managing the IV. Take the funny patient, for example. There's this amazing anecdote from our source material where a patient wanted to count backwards, bragging, "I got a liver of steel. I bet I can count backwards from 10 twice before I fall asleep." And the funniest part? The guy actually pulled it off. But because propofol instantly blocks memory formation, he woke up in recovery and aggressively accused the poor resident of lying, completely unable to remember his own epic countdown.
Then you're going to get the insanely nervous or just extremely chatty patient. We have a great pharmacological tool for this, midazolam or Versed. You give this a few minutes before general induction and it wonderfully melts away the anxiety. But a quick warning, it can totally act like a truth serum. It's famous for turning nervous energy into hilarious, nonstop rambling. You might have a patient passionately reviewing YouTube videos or randomly declaring how much they love feeling inside and outside the medication. Honestly, just let them talk. If they're safe and comfortable, you are crushing it.
But soft skills aren't just about drugs, right? It's about environmental control. A ton of residents carry around a little Bluetooth speaker just for this. If you ask a terrified patient what music will calm them down, you better be ready to honor that request. One resident had a patient completely deadpan ask for underground European rave music from the late 90s. And hey, blasting that or cranking up some reggaeton might earn you some wildly confused looks when the surgical team finally strolls in. But if it comforts that patient as they drift off, it is a highly effective, completely valid clinical tool. And finally, the pediatric strategy. Kids are a whole different ballgame. You obviously can't just reason with the toddler about the importance of denitrogenation. The goal here is total distraction, dissociating reality. That scary pulse oximeter? No, that's a cool light-up astronaut finger clip. Even better, you can actually drop bubblegum flavor concentrate right onto the oxygen mask during the pre-oxygenation phase. It's this brilliant little trick to keep their minds completely occupied while you secure the mask over their face. Which leaves us with this final thought for today. You now have the exact physical steps down, that critical IV prologue, the essential monitors, the vital denitrogenation process, and the lightning-fast 10-second propofol window. But as you practice and inevitably master this rigid, clinical checklist, I want you to ask yourself, how are you going to adapt your own soft skills to comfort the highly unique, incredibly vulnerable person breathing underneath that mask? Because at the end of the day, the absolute best anesthesiologists don't just master the hard science, they master human empathy. Thanks so much for tuning into this explainer, and I'll catch you on the next one.